Welcome to the JVSVL and the 4 papers that highlight the range of venous research reported in this month's journal. The first paper, left iliac vein compression, is not associated with infrainguinal deep vein thrombosis, but is associated with iliac vein involvement by Chen and Associates, investigated left iliac vein compression to determine whether it had a correlation with the risk of both left deep venous thrombosis and left-sided infrainguinal DVT. They did a retrospective analysis of 278 patients with left-sided DVT, 228 of whom had iliac DVT, 50 of whom had infrainguinal DVT, and 232 control patients without DVT on either side. The mean percentage of compression by CT scan of the left iliac vein was significantly higher in proximal DVT patients than it was in non-DVT patients. However, compression of the left iliac vein in left infrainguinal DVT patients was significantly lower than in non-DVT patients. The authors concluded that left iliac DVT patients had more severe left iliac vein compression than left inguinal DVT patients did. Left iliac vein compression was not associated with the development of left infrainguinal DVT, but it did correlate with the presence of left-sided DVT with iliac vein involvement. The next paper, a randomized trial of class 2 and 3 elastic compression in the prevention of recurrence of venous ulceration by Milich, investigated patients with healed venous leg ulcers, determine how long compression hosiery should be worn after venous ulcer healing, and to determine whether class 2, which is a lower pressure of 30 to 40 millimeters of mercury, or class 3, which is a higher compression, in that hosiery better achieves the results in the prevention of venous leg ulcer recurrences. They did a prospective randomized study with a 5-year follow-up of class 2, the lower pressure, and class 3, the higher pressure hosiery, in patients with healed venous leg ulcers. 361 patients were randomized, and 308 patients completed the study. All patients were instructed to wear compression stockings continuously for the first 2 years of follow-up, day and night. In the 3rd, 4th, and 5th years of follow-up, patients were instructed to wear elastic stockings during the day only. The rates of ulcer recurrence after 5 years of follow-up were 29% in the class 3, that is the higher pressure group, and 60% for the class 2 or lower pressure group. Rates of non-compliance after 5 years were 10% for the class 3 group and 6% for the class 2 group. The authors concluded that class 3 compression stockings provide a significantly lower recurrence rate compared with the class 2 compression stockings. The next paper, vein diameter is a predictive factor for recanalization in treatment with ultrasound-guided foam sclerotherapy, by Tenolio, investigated ultrasound-guided foam sclerotherapy treatment of varicose veins between 2010 and 2017. Both great saphenous vein and small saphenous vein were treated, and they attempted to determine whether vein diameter predicts obliteration failure. There were 457 treatments in 290 patients, with a great saphenous vein treated in 81%. Mean vein diameters of the great saphenous vein of approximately 6 millimeters were not significantly different from those of the small saphenous vein. At 6 weeks post-treatment, complete obliteration, partial recanalization, and complete recanalization rates were 55, 29, and 16% respectively. Of those with complete obliteration at 6 weeks, the recanalization rate at 1 year was 25%. Increasing vein diameter was associated with increasing recanalization at 1 year. Since only 44% of the ultrasound-guided foam sclerotherapy procedures were observed to have complete obliteration at 1 year, the authors advised caution in using foam sclerotherapy, particularly in patients with large veins, since significant recanalization developed at 1 year. The final paper for this month, catheter-directed thrombolysis through the anterior tibial vein for treating acute extensive deep vein thrombosis by Wang, evaluated an anterior tibial vein approach for acute extensive lower extremity DVT. 125 consecutive patients with acute extensive lower extremity DVT received catheter-directed thrombolysis through an anterior tibial vein between 2014 and 2017. Patients with iliac vein compression were also treated with balloon dilatation and stent implantation after the catheter-directed thrombolysis. The anterior vein approach was successfully achieved in 94%, with a mean thrombolysis time of 5.3 days. The average dose of urokinase was 3,900,000 international units. Metal stents were placed in 42% in the iliac vein. The limb circumference was significantly reduced with thrombolysis. The incidence of bleeding was 10%, with 3 patients suffering a major bleed. 2 patients had accidental anterior tibial artery injury, but recovered without complications, and no nerve injury occurred. During a mean follow-up of 19 months, femoral and popliteal venous insufficiency was present in 21% and 31% of patients respectively, and the overall patency and post-thrombotic syndrome rates were 84% and 22%. The authors concluded that catheter-directed thrombolysis through an anterior tibial vein approach is a feasible, effective, and safe procedure and can be an alternative to the traditional catheter-directed thrombolysis approach. We hope you enjoy each of these papers and the others in this month's Journal of Vascular Surgery, Venous and Lymphatic Disease. And thank you for listening.